Hi, for my elective ortho rotation, I'll be presenting a case on a knee injury that I saw in clinic. So this is a 28-year-old female who presents to the clinic with right knee pain that occurred on the 6th of July, 2024 during a softball game after planting her foot to catch a ball and twisting quickly to release the ball. The patient states that her teammates saw her hyperextend her knee, while she says that she witnessed her kneecap move to the side of her leg, while also feeling a pop and crunch sensation at the time of the injury. She points to the pain at the lateral, medial, and posterior aspect of the right knee, and she states that she cannot fully straighten or bend the right knee. She admits to mechanical symptoms such as popping, clicking, instability, and knee buckling. She also reports that the quality of her pain is a constant aching that is aggravated with weight-bearing activity, causing a very sharp pain in the knee. She denies any redness, abrasions, fever, chills. She also denies right hip or ankle pain. She reports a mild to moderate decrease in swelling since the injury occurred on the 6th of July. Prior treatments include elevation, rest, ice, Tylenol for pain, and an over-the-counter knee brace for stability. The patient has never experienced an injury like this before and is concerned because her knee has not improved since the injury occurred. Regarding her past medical history, she reports asthma and IBS-C. Her current medications include an albuterol inhaler as needed, Miralax once a day, and melatonin 3 milligrams as needed for sleep. She is allergic to bee stings and peanuts, causing an anaphylactic reaction. Her past surgical history includes a tonsillectomy in 2007. She recalls or reports no other hospitalizations. Previous injuries include a history of multiple ankle sprains from playing soccer as a child. She reports a broken left ankle that occurred in 2008. It was a Salter-Harris type 2 fracture with no complications. She is up to date on routine vaccinations and screenings. She currently works as a research assistant who is highly active and enjoys participating in soccer and softball recreationally several times during the week. She consumes 3 to 4 alcoholic beverages a week on weekends and social settings. She denies the use of tobacco, vaping, or partaking in illicit substances, including marijuana. She is currently married and not using hormonal contraception. Her review of systems is negative besides what has been reported in the HPI. So moving on to her physical examination. Upon observation, the patient is alert and oriented ×4. She is properly draped and well groomed with no malodors of body or breath. She appears to be her stated age and is in no acute distress. Her gait and alignment is antalgic and asymmetric. There are no wounds, ecchymosis, or erythema appreciated of the right knee upon observation. However, there is a visible effusion and swelling of surrounding structures. Upon palpation, positive tests or tests that elicit pain include pain along the medial joint line, pain appreciated along the medial collateral ligament, pain appreciated at the lateral joint line. However, there was no pain observed when palpating along the lateral collateral ligament. There was also no global knee tenderness appreciated, no tenderness at the tibial tubercle, patellofemoral joint, or quadriceps tendon. Regarding range of motion, the right knee is able to extend at a maximum of 10 degrees, so she is not able to fully straighten the knee, and flexion is able to reach a maximum of 90 degrees without pain, indicating that the patient cannot fully flex the knee. There was no crepitus palpated with range of motion, and her patellar tracking is within normal limits as there was a negative J sign. Her strength with the right knee extension and flexion is 5 out of 5. And other special tests performed include a Lachman's giving a 2+ result, anterior drawer giving a 2+ result, indicating a potential ACL injury, as well as a guarded response from the patient during the pivotal shift test, also indicating a potential ACL injury. The patient exhibited pain when valgus force was applied at 0 and 30 degrees of flexion. There was also pain observed with the medial and lateral McMurray's test. Posterior drawer test was negative, stable, and there was no pain with varus force applied at 0 and 30 degrees flexion. Patellar compression and apprehension tests were also both negative. Her neurovascular exam of the right extremity showed 2+ dorsal pedal and posterior tibial pulses with a brisk capillary refill under 2 seconds. Her sensation is intact distally to light touch. And regarding the left knee, there were no deformities, no swelling. It was non-tender. She has pain-free range of motion. Her strength with extension and flexion of the left knee are 5 out of 5. She had negative lateral and medial McMurray's and negative for instability. Regarding my differential, it would include a partial or complete ACL tear, along with a medial meniscus tear and or a medial collateral ligament sprain. This is referred to as the terrible triad, as with ACL pathologies, other structures tend to be involved, and the medial meniscus and MCL are commonly involved. But other injuries the patient could have sustained could include a lateral meniscus tear, a lateral collateral ligament sprain, patellofemoral dislocation, joint effusion, or a tibial plateau fracture. Now, in clinic, 4 plain film X-ray views were ordered. This includes a standing AP, lateral, sunrise, and a notch view. This showed normal joint space, not indicating any arthritis. There were no osseous abnormalities or avulsion fractures. However, there was a right knee effusion appreciated with plain film imaging. Now, regarding the patient care plan and treatment, the patient was advised to continue to ice, rest, elevate her right leg, along with, continue taking Tylenol for pain relief. And she was discouraged from weight-bearing activity. So she was encouraged to continue wearing the stabilizing brace that she purchased over the counter, but advised not to weight bear on the right knee. Now, she was sent home with explicit instructions on different lower extremity exercises to conduct to prevent a deep vein thrombosis. So an exercise, for example, would include calf pumps that mimics the action of the patient pressing on an imaginary gas pedal. This engages the calf muscles and helps to promote blood flow against gravity to prevent the development of a deep vein thrombosis. Now, the patient was also referred to obtain an MRI of the right knee without contrast to evaluate for next steps, given the high likelihood of surgical planning. Arthroscopy is the gold standard in evaluation for ACL tears and related injuries, so a downside may be that the MRI may not catch a meniscal injury. However, it is the most sensitive and specific when it comes to the detection of soft tissue injuries, as our concern is for this patient case. The patient education includes explaining the mechanism of injury and demographics of ACL tears. So it is experienced frequently by female athletes or in trauma victims after, let's say, a motor vehicle crash. The anterior cruciate ligament is an important stabilizing ligament of the knee. So we know that ligaments connect bones together, 2 bones together. The knee itself contains 4 major ligaments connecting the femur or our thigh bone to our tibia, which is our shin bone. And we have our medial and lateral collateral ligaments that prevent side-to-side movement of our leg. And we also have the ACL and PCL, the posterior cruciate ligament that prevents forward and backward translation of our shin relative to our thigh bone. So the mechanism of injury frequently occurs when people are running or jumping and then pivot or change directions, quickly rotating or bending at the knee sideways. People who sustain an ACL injury often report a pop at the time of injury, along with knee instability, which again is what our patient reported in this case. The meniscus is another structure of the knee joint that promotes stability, which could also potentially cause the patient's knee buckling or feeling unstable. And it is important to note that nearly everyone who sustains an ACL injury develops swelling of the knee joint due to bleeding from damaged blood vessels. And this is what's called an effusion. ACL injuries are treated either non-surgically with physical rehabilitation or with surgery and physical rehabilitation in patients who are highly physically active, who participate in sports or have physically demanding jobs, have severe instability when standing on the affected leg, or patients who have completed physical therapy and still continue to suffer with instability and buckling of the affected joint. If the ACL is ruptured, a healthy tendon needs to be used for reconstruction. Now, a tendon is different from a ligament because a tendon connects muscle to bone, but it can be used to replace the ACL. Common sites include the patellar tendon or hamstrings tendon. During surgery, the ACL is removed via arthroscopy. This is when a teeny tiny camera, light source, and small instruments are introduced to the joint space through very small incisions. After the procedure, the knee is wrapped in a sterile dressing and placed in an immobilizing brace. But it is also important to note that surgery is not a quick fix. It involves a very challenging recovery period that requires a commitment to the rigorous physical rehabilitation that's necessary to regain strength and stability in the knee. So this patient should anticipate following up in 2 weeks after she has obtained the MRI without contrast to move forward with surgical planning. She will continue non-weight-bearing activities along with the lower extremity exercises that she was sent home with. And she's encouraged to continue icing, elevating, and taking Tylenol for her pain.